Hello everyone and welcome back to my channel. So today's topic is autoimmune cholangiopathies, and you know that this is such an important topic from the point of view of Neet PG examination. A lot of MCQs are asked, and there are only two entities. Number one is the primary biliary cholangitis, and number two is the primary sclerosing cholangitis. So these two entities are very confusing, and you must remember which comes under which entity. So this is going to be a very important video for MCQ based exam, and so without further ado, let's dive straight into this topic. So this chart is very important, and I'm first going to take you through this chart because this is ultimately what you have to remember, and then I will come to the details of each of this. Now, primary biliary cholangitis and primary sclerosing cholangitis. First of all, I want you to remember that which is predominant in which gender. So there is a difference of only one word. This is biliary and this is sclerosing. The rest of the two words are same in both these entities. So biliary is more common in the females and sclerosing is more common in the males, right? And I will tell you one mnemonic also, but just listen to this first, that in the biliary cholangitis you have the AMA positive, which is the anti mitochondrial antibody positive in primary biliary cholangitis, and it is the ANCA positive which is present in the sclerosing cholangitis, right? So you must know that radiology mein this is normal, and in the sclerosing cholangitis you have the beading of the large bile ducts. Okay, I will come to the pathogenesis and everything, but just first try to remember these points because ultimately this is the high yielding chart present here. And what is the duct lesion or the histology? So in the biliary cholangitis, you are going to find florid duct lesions and loss of small ducts. You have to remember these words exactly as it is written, okay? Because it may not be possible for you to understand this exactly histologically, but these points and these words are very important for your exam. And primary sclerosing cholangitis may it is the destruction of the extrahepatic and the intrahepatic duct. So the point that I'm trying to make here is that in the primary biliary cholangitis, you have a lymphocytic infiltration. So the histologic picture here is lymphocytic and granulomatous bile duct destruction, which is known as the florid duct lesion. This is characteristic of PBC. I cannot stress any more on the importance of these 2 points. Very important. If I can just write them down over here, the two important points is, so florid duct lesions, what does this mean? Number one, it will mean lymphocytic or granulomatous bile duct destruction. Okay, this is exactly what you have to remember for your MCQs, and this is known as the florid duct lesion. Very important term, or rather you can say it the other way around. The both of the things are same, and this is characteristic of a PBC, lymphocyte as well as granuloma. Both these terms are very important for PBC. And now if you come to sclerosing cholangitis, then the words which are most important is the onion skin appearance. So here you can see that in the histology what you want to find is that the inflammatory injury can result in circumferential onion skin fibrosis, which is the periductal fibrosis or sclerosis around an increasingly atrophic duct lumen, eventually leading to obliteration by a tombstone scar. So onion skin fibrosis, this is what you can see over here. So this is a degenerating bile duct which is entrapped in a dense onion skin concentric scar. You can see this is basically the onion skin concentric scar. So the points that you have to remember is onion skin and tombstone scar. So if you get these 2 points in your MCQs, then that will point to primary sclerosing cholangitis. Okay, so I will just write it down over here, that onion skin fibrosis, and number 2, tombstone scar. Okay, these two are the histological kind of findings, and also you have to remember that there is inflammatory destruction of the extrahepatic and the intrahepatic duct. This is also a very important point. There is fibrotic, there is fibrosis over here because of which there is obliteration of these ducts. Okay, and of course there is ductular reaction in the small portal tracts, and you have the onion skin fibrosis. So this histologic findings is very important. The duct lesion is very important. You should not forget these terms because there are very few terms here, and don't confuse between them. Just read this chart, and that's why I am putting all the points here at one place. And as I mentioned that in the radiology, this is going to be having beading and strictures of large bile ducts and pruning of a smaller ducts. You have to remember, you have to by heart this. Even if you don't understand, doesn't matter, you have to by heart this chart because exam में इसी में से options आएंगे. And this is normal. Okay, so very important, this is normal, but you have findings in this sclerosing cholangitis. And another very important point, this is going to be your AMA positive. This is AMA positive. 95% is AMA positive. Along with that, 40 to 50% is ANA positive, which means in the exam, in the MCQ, if you get this option also, both of them is going to be positive. It is not only AMA, ANA or anti-nuclear antibody is also positive. Okay, so if you get an option in which both of these are mentioned, that is going to be the correct option. Okay, but if you talk about the sclerosing cholangitis, you see that 65% they have ANCA positivity, and ANA is variable and EMA is typically negative. So here you will find that there is no presence of EMA over here, which means anti-mitochondrial antibody is the differentiating feature between this primary biliary cholangitis and primary sclerosing cholangitis. And now if you talk about the associated conditions, here 70% associated with Sjogren syndrome, and here it is the inflammatory bowel disease. Now if I talk about a small mnemonic, I don't know how much it will help you, but this was what I learned when I was preparing. And so this is basically about ma and uncle, right? So uncle may we have anka positivity, okay? And anka positivity means this is uncle is also a male, right? And the male is also having some kind of bowel disease, ठीक है? और मेल जो है बहुत टफ होते हैं ना, फीमेल के कंपैरिजन में मेल बहुत टफ होते हैं. So you are going to have fibrosis, because that ultimately will lead to this tombstone scar and onion skin fibrosis. So usually that would mean that a kind of a tougher person. That is not happening in case of the biliary cholangitis. So ये सारे points आप अंकल से आता है अंका, उसके साथ में क्योंकि अंकल है तो मेल है, एंड अंकल इज ऑल्सो हैविंग सम काइंड ऑफ इन्फ्लेमेटरी बाउल डिजीज. एंड लड़के लोग यूजुअली बहुत स्ट्रॉन्ग होते हैं, फाइब्रोटिक होते हैं, तो इसीलिए फाइब्रोसिस. ओके, and this is basically the primary sclerosing cholangitis. Okay, and if you talk about the primary biliary cholangitis, then ma, ठीक है, ma मतलब obviously it is going to be female then, and positive serology is going to be ama positive. So यहाँ पर ma है, ठीक है, तो यहीं से आता है ma, ठीक है, तो माँ है इसीलिए फीमेल है और इसीलिए इट इज पीबीसी. एंड यू हैव अ फ्लोरिड डक्ट लेशंस ओवर हियर, ऑल्दो यू हैव टू रिमेंबर ऑल दिस वर्ड्स इन डिटेल. तो ये छोटा सा एक कोशिश है ताकि आप इसको याद रख पाओ. इज जस्ट अ वेरी स्मॉल न्यूमोनिक एंड नथिंग मच. You have to read this. This is going to be one of your last minute revision chart for your MCQ based exam. I just can't stress anymore on the importance of this. And now I'm going to take you through each of this in detail. So first, talking about the primary biliary cholangitis, is an autoimmune disease characterized by inflammatory destruction of the small and medium-sized intrahepatic bile duct. Very, very important. Here we have seen that there is destruction of the extrahepatic and intrahepatic both, but here it is the only intrahepatic which is kind of affected. Okay, and it is small and medium size. These words are very important. एग्जाम में ऑप्शंस आएंगे जिसमें ये छोटे छोटे डिफरेंसेस जो है दैट विल बी रियली रियली इंपॉर्टेंट. सो दिस विल इन्वॉल्व ओनली द इंट्राहेपेटिक बाइल डक्ट. Along with that, there is destruction of the small and medium sized only. And this is an autoimmune disorder resulting from the T lymphocyte mediated attack on the small interlobular bile duct. So basically this is having a T lymphocyte mediated attack. Again, a very important MCQ point. Okay, now, yes, environmental factors are the trigger which leads to expression of the autoantigens on the bile duct epithelial cells. So basically what's happening here, this is basically an autoimmune disorder, and therefore what is the antigen, what is the autoantigen against which the body is reacting? It is the autoantigens present on the bile duct epithelial cells which is actually becoming the antigen, and now the body is reacting against it, and that is why there is resultant destruction by the T lymphocytes. The retention of bile salts due to bile duct injury leads leads to secondary hepatocellular injury as well in PBC, which can eventually produce a cirrhotic picture. So very important, cirrhosis can be a finding of PBC. Why? Because whenever the bile ducts are destroyed, that will also lead to a secondary liver injury or hepatocellular injury, because of which there can be a cirrhotic kind of a picture. Now, anti-mitochondrial antibodies are directed against the E2 component of the pyruvate dehydrogenase complex, which is the most characteristic finding in PBC. Again, a very important point. I just can't stress any more on the importance of this point, because you can see that these antibodies, I already mentioned the importance of these antibodies. Yes, these are present, but what is that against which these are directed? These are directed against the E2 component of the PDC, which means pyruvate dehydrogenase complex के E2 component के against में these antibodies are directed, and this is the most characteristic finding in the PBC. So if you are asked which is the most characteristic finding, this is going to be number 1, and here you can see that histology में this is the histological picture which is highly characteristic. So these two are the characteristic points of primary biliary cholangitis. Hallmark I've already explained, lymphocytic infiltration of the epithelial injury. There is a lymphoplasmacytic inflammation and ductular reaction which are often present. The disease progression leads to loss of small intrahepatic bile duct, which is known as ductopenia. So this is also a very important point, which is there is ductopenia of the small intrahepatic bile duct. So I'm going to just add this point over here so that this becomes your last minute revision chart with all the points involved. Here something else is happening, and that is there is ductopenia, okay, of what? Of intrahepatic bile ducts, right? Because here only the intrahepatic bile ducts are involved, and here the intrahepatic and posthepatic both are involved. So I'm just going to highlight this. This is going to be intrahepatic and extrahepatic, both are involved, but here only the intrahepatic ducts are involved. So this was an important point. Another important point is that the medium and the small sized ducts which are involved. So this is going to be, this is not that important a point, but then I will just mention it over here that this is medium and small ducts which are involved. Obviously they are the intrahepatic ducts only. Another point is that there is a T lymphocyte mediated attack, okay. Okay, the next point is that the antimicrobial antibodies are directed against what? Okay, so this is basically directed against the pyruvate dehydrogenase complex, the E2 component of that. This is basically directed against this. So I have kind of tried to put all these things in one particular place. I hope that you are able to understand this. Next, coming to this image, here you can see these images are also extremely important. They can just put up this image and ask you questions. So first you have to know that what is this image, right? So this is an image of primary biliary cholangitis. You can see that the portal tract is markedly expanded by an infiltrate of lymphocyte and plasma cells surrounding a destructive granulomatous reaction centered on a bile duct which is called as the florid duct lesion. So basically there is infiltration of so many different kinds of cells here, as well as there is also a granulomatous reaction. So you must be having a basic understanding of the general pathology and how this formation of granuloma, etc., etc. So you must be knowing that there is a granulomatous reaction happening, along with that lymphocytes, plasma cells all are present, and therefore it is called as the florid duct lesion, because there are so many different kinds of cells at one position. This is how the picture looks like. So if it is like this is going to be a primary biliary cholangitis, because in biliary you have florid duct lesion, and if you see this kind of an image, this is going to be an onion skin fibrosis which is seen in primary sclerosing cholangitis. So another important point is that the stasis of the bile salts leads to swelling of the periportal hepatocytes, which have clear cytoplasm with granular strands, which is known as the feathery degeneration. So again, a very important point, feathery degeneration of the hepatocytes is seen here. I've already mentioned before that there is hepatocellular injury along with the bile duct injury. So this is also an important point, and I'm going to just write it down over here. Although there's no place here, but क्या ही कर सकते हैं. going to be the point that I'm going to write. This is going to be feathery degeneration of the hepatocytes, right? And why hepatocytes? Because you know that there is also hepatocellular injury along with the bile duct injury. Now another point is that the end stage disease culminates in cirrhosis. So the liver is also very much affected. The cirrhotic nodules in the PBC tend to be elongated or garland shaped. So garland shaped cirrhotic nodules, okay? And if ever there is some kind of cirrhosis, then you find garland shaped cirrhotic nodules in this particular entity. Okay, now if you talk about the clinical features, then you have fatigue, pruritus, splenomegaly, jaundice, hyperpigmentation, xanthelasma, steatorrhea, vitamin D malabsorption, osteoporosis, and the diseases associated is Sjogren's syndrome, a very important MCQ point already given in your chart, and then systemic sclerosis, thyroiditis, rheumatoid arthritis, Raynaud's phenomenon, all of these points. Now, antimicrobial antibodies are present in 90 to 95% of the patient at all stages of the disease, which is a highly characteristic. The diagnosis can be established if two of the following are present. Now this part is very important, which I can't write in that image, and you must know the diagnostic feature. So two out of the following has to be present. So which are the points? Number one, elevated alkaline phosphatase for more than 6 months, positive test for antimicrobial antibody number 2, and the characteristic histological findings number 3. The EMA negative of the disease has only two of the findings and is sometimes termed as the autoimmune cholangiopathy or autoimmune cholangitis. So you know that 95% of them are EMA positive and 5% of them are EMA negative. So when you say EMA negative, they only need two of these findings, right? They only have rather two of these findings, and this is something which is called as the autoimmune cholangiopathy. So if you're asking autoimmune cholangiopathy में क्या मिलता है आपको, तो एमा नेगेटिव होता है इन सारे केसेस में, राइट? सो एमा पॉजिटिव है तो मतलब प्राइमरी बिलियरी कोलेंजाइटिस, और अगर एमा इज नेगेटिव देन इट इज autoimmune cholangiopathy. Okay, and here this you should not miss out on this particular diagnostic points, that two of these has to be present. And what are these points? Elevated alkaline phosphatase for more than 6 months, positive test for EMA, right? And number 3 is the characteristic histological findings. And you can see here that if you find that this EMA, right, if this EMA is basically negative, if it is negative, then it is ultimately pointing to autoimmune cholangitis. So you understand now, obviously the treatment is with oral ursodeoxycholic acid. Again a very important MCQ point. ठीक है, ये भी एक बहुत इंपॉर्टेंट सवाल है कि ट्रीटमेंट में क्या देते हैं. इट इज ओरल अर्सोडिऑक्सीकोलिक एसिड. एंड नाउ लेट्स कम टू दिस सेकंड पार्ट व्हिच इज टॉकिंग अबाउट द प्राइमरी स्क्लेरोसिंग कोलिंजाइटिस. सो दिस इज कैरेक्टराइज्ड बाय इन्फ्लेमेशन एंड ऑब्लिटरेटिव फाइब्रोसिस ऑफ द एक्स्ट्रा हेपेटिक एंड लार्ज इंट्रा हेपेटिक डक्ट. तो यहाँ पर दोनों ही इन्वॉल्व है. मैंने पहले ही बोला कि यहाँ पर दोनों ही इन्वॉल्व है एंड यहाँ पर फाइब्रोसिस हो रहा है, राइट? सो अंकल वाज वेरी टफ, ठीक है, इसीलिए फाइब्रोसिस हो रहा है. And there is a male predominance, and what's happening over here is that the presence of circulating autoantibodies and T lymphocytes in the periductal stroma in associations with HLA-B8 and other MCH antigens and ulcerative colitis all support the idea that PAC is an immunologically mediated process, right? तो एक और बात है कि इट इज एसोसिएटेड विद आईबीडी में भी इट इज एसोसिएटेड विद अल्सरेटिव कोलाइटिस. तो इसीलिए मैंने यहाँ पर बोला है ना कि अंकल है, तो यहीं से आपको एक और भी पॉइंट मिल जाता है कि आईबीडी मतलब अल्सरेटिव कोलाइटिस. सो यू से यू मैचिंग है, सो अंकल में आपको यू से मिलेगा मतलब अल्सरेटिव कोलाइटिस मिलेगा मतलब आईबीडी मिलेगा. सो हियर ऑल्सो यू हैव दिस कनेक्शन and this therefore becomes your mnemonic. So coming back to this, I was talking about another important point, and that is the presence of association with HLA-B8. Again, a very important point. So you must remember all these important points. These are all MCQs. This can be framed anyhow and any way into your MCQs, into your options, because this topic is very important, right? It is a previous year's question topic. You must be knowing that. And now if you talk about the pathogenesis, then now what's happening here is that the intrahepatic bile duct and extrahepatic duct, they show epithelial injury, neutrophilic infiltrates, and ultimately they cause fibrosis and narrowing and stricture of the lumen. And this fibrosis is basically onion skin fibrosis, which is the periductal fibrosis. So even in the question, if you get the word periductal fibrosis, it is still going to be the correct option. And yes, you have the tombstone scar ultimately. Progression of cholestasis and fibrosis culminates in biliary cirrhosis. Biliary intraepithelial neoplasia can develop and eventually lead to cholangiocarcinoma, a rare complication of PSC. So what is the complication of PSC? PSC can give rise to biliary intraepithelial neoplasia, which can give rise to cholangiocarcinoma. This risk was not there in primary biliary cholangitis. So I will just again mention this point here because I feel this is very, very important. This can be a future question, that PSC can get converted to biliary intraepithelial neoplasia, and this can again get converted to cholangiocarcinoma. So this is therefore a very, very dangerous, right? So this complication is not there in case of primary biliary cholangitis. Okay, obviously the clinical features are almost the same. There's fatigue, pruritus, jaundice, etc. Yes, there's elevation of the serum alkaline phosphatase. Ascending cholangitis can be an initial presentation. Yes, this is very, very important point. The gold standard for diagnosis of PSC is the characteristic beading, which is seen in the large intrahepatic and the extrahepatic biliary tree by the ERCP or the MRCP. So this is an important point, that beading is present in the hepatic ducts, and this is what is the gold standard for diagnosing of PSC. Now, when there's involvement of the smaller bile duct only, it is called as the small duct PSC, and that can progress to large duct PSC. And classic PHC or large duct PSC needs to be distinguished from cholangitis that occurs in the IgG4 sclerosing disease, which is steroid responsive and often associated with pancreatitis. So there's just an important difference that they're trying to make over here. And of course, the treatment is that the cholestyramine can be used to alleviate the pruritus, and liver transplantation can be done for the end stage liver disease. So this is the end of this topic. This is an image of MRCP where you can see, this is an image of magnetic resonance cholangiography where you can see there is focal dilatation of this small bile duct, and in the other places there is stricture or thinning of the ducts. Okay, so this is basically the entire topic. I hope I have been able to make this clear, and you cannot just afford to forget this particular chart. This is a very, very important last minute revision topic for your exams. So I hope you enjoyed watching this video. If you like my content, then please consider subscribing. I will come up very soon with the next episode. Till then, take care, keep studying, and thank you for watching.